Okay, monoamine oxidase inhibitors. So we're kind of moving into the realm of antidepressants. A couple of things that I want you to know about that's in general about antidepressants. They typically all work equally well. The differences are in their adverse effects and in the individual that's taking them. So one antidepressant may work better for person A than person B. It's not necessarily the drug, it's just that person. And so sometimes use of antidepressants is trial and error till they find the one that's going to work for that individual. Another general rule is that response time is typically 2 to 4 weeks at adequate dose. Well, what does that mean? That means that physical symptoms typically of depression, such as alterations in appetite, alterations in energy level, these typically will begin to disappear at 2 to 4 weeks, within that time frame. And adequate dose means that we don't want to stop and change medications every 2 to 4 weeks if it isn't working. It may mean that the dose of that drug isn't high enough for that person. And so not only do the drugs work, some of the medications work better for some people are going to require higher doses than other people. And it doesn't necessarily have to do with the severity of their depression either. As a general rule, if by the end of 6 weeks they've had no response, then it's time to look at changing medications. The other thing that is common to all of the antidepressants is that we have to consider the risk of suicide when they start therapy. And the reason for that is not necessarily that the drugs themselves cause an increase in suicide risk, but that for some people who are depressed and may be suicidal, it's the fact that they don't have the energy to follow through. And so we start them on the antidepressants and they begin to feel better. They have a little more energy. They still don't feel good psychologically, but they feel better physically. And that may be just enough of an edge for them to say, okay, now I have the energy to finish what I couldn't even start before. Increase of risk of suicide is greater in children taking antidepressants, and so we have to be especially cognizant of it. Now, MAOIs, or monoamine oxidase inhibitors, aren't used very frequently anymore because we have better medications, and by better I typically simply mean that they have fewer side effects. So what do monoamine oxidase inhibitors do? They prevent the breakdown of neurotransmitters by monoamine oxidase. I don't know why I can't say that. And I think I mentioned before that when we see the ACE at the end of a word, it usually means an enzyme that breaks something down. And that's what an MAO is. It breaks down the neurotransmitters. Again, typically here we're talking about the neurotransmitters norepinephrine, epinephrine, serotonin, and dopamine. And norepinephrine and serotonin are two neurotransmitters that play a huge role in mood. And so we want to make sure that these neurotransmitters are available in sufficient quantities. So when we inhibit MAO, we prevent the breakdown of these neurotransmitters. And again, so that's going to allow for higher levels of these neurotransmitters to be available. So what that means for our depressed patient is that now serotonin is available in that synaptic cleft so that it can move down the line of that nerve fiber and keep the mood elevated. MAOIs are typically the last line of defense because of their large number of side effects and dietary restrictions and restrictions on other meds. MAOIs have a huge number of medications that they interact with. So primarily they're used as an antidepressant when other antidepressants aren't effective. They can be used for panic disorders, obsessive compulsive disorders, phobias, that along those lines. The action of the drug doesn't change. The side effects don't change. The interactions don't change just because we change what we're using it for. What's going to change is the therapeutic outcome. I'm going to anticipate a different therapeutic outcome for panic disorder than I would for if I'm using it for depression. So again, I think that you can kind of figure that out. Adverse effects include anticholinergic effects, so again, dry mouth, constipation, blurred vision, all of that. Orthostatic hypotension is common, as it sometimes is insomnia, and we can sometimes alleviate that simply by adjusting the dose or adjusting the timing. One of the most serious side effects of MAOIs, if they use it, if they don't pay attention to their dietary restrictions and they don't pay attention to their medication restrictions, then hypertensive crisis is probably the most likely event to occur. Symptoms include occipital headache, stiff neck, flushing, palpitations, profuse sweating, nausea. And those are all symptoms, obviously along with a high blood pressure, of hypertensive crisis. Hyperglycemia can also occur, and so we would want to monitor that closely for patients who are diabetic. So dietary restrictions, like I said, big deal. They cannot have foods that contain tyramine. So what is tyramine found in? We can find tyramine in wine, cheeses, liver, avocados, bananas, raisins, any processed meats, pepperoni, sausage, bologna, even in chocolate. So we want to make sure when we're doing our history that they haven't had any of those foods in the last few days and that they know not to take those foods while they're taking an MAOI. MAOIs were more likely to see the hypertensive crisis when using other antidepressants, when using sympathomimetics, and with those foods. We need the patient to have stopped the MAOI a minimum of 2 weeks before they start any other antidepressants. And we have to consider that even over-the-counter medications can interfere with the MAOIs and cause this hypertensive crisis. Cough medicine is probably one of the worst offenders because of the dextromethorphan and phenylpropanolamine that is found in most over-the-counter cough medicines. So lots of interactions. They need to stop the MAOI 2 weeks before starting any of these other medicines and not have taken an MAOI for several days before starting, or not to start an MAOI what do I want to say? Give me just a second to think about what I'm trying to tell you is there should be stop the MAOI a couple of days before. Well, so 2 weeks, no MAOI before SSRIs or any of these other meds, and a couple of days of break between the SSRIs and MAOI, I think is what I'm trying to tell you. They shouldn't use it if they have renal disease, liver disease, or any cerebrovascular disease. If they experience hypertensive crisis, could cause a stroke, brain aneurysm could rupture, that sort of thing. SSRIs, or selective serotonin reuptake inhibitors. So these medications work by slowing the reuptake of serotonin. So the receptors on the postsynaptic side are more sensitive. There's more serotonin available. So you kind of have to understand what we mean by reuptake. With serotonin and norepinephrine, when we're talking about mood, the presynaptic neuron sends out the serotonin as a neurotransmitter, and it sits in that synaptic cleft or synaptic space. And then if it isn't taken up by the postsynaptic neuron, then the presynaptic neuron sucks it back up, so it's no longer available. So what the SSRIs do is say to the presynaptic neuron, you can't have it back. It blocks it from going backwards, only allows it to go forward. And that is going to help us to alleviate the symptoms of depression and improve mood. So its primary use for SSRIs is to relieve depression. But again, it can be used for obsessive compulsive disorder, bipolar disorder, or panic disorders. SSRIs usually are the drug of choice for treating depression because they have a greater safety margin than our MAOIs or even the TCAs, which we'll talk about later. The other advantage to SSRIs is that they don't tend to have the anticholinergic effects or the cardiovascular risks. And just kind of on a side note, I'm talking about antidepressants and listening to Pharrell Williams' Happy. I just thought that was kind of a fun coincidence just now. That song came on and it's making me happy. It's my personal antidepressant. And if you don't know the song, you should look it up and listen to it. It'll make you happy too. So, sorry. Serotonin syndrome, or SES, is the greatest risk that we have with SSRIs. And we're certainly going to see serotonin syndrome if the SSRI is taken with an MAOI, a TCA, or lithium. So we want to be observant for that. And symptoms of serotonin syndrome, again, can mimic or are very similar to the hypertensive crisis that we would see with the MAOI. Adverse effects are the same as anticholinergic effects, but we don't see that very often. Probably the greatest adverse effect that causes most people to stop the SSRI would be decreased libido. So the desire for intercourse is reduced, and or the ability to reach orgasm is also reduced. Men may experience delayed ejaculation and impotence. A headache is a frequent early side effect that usually resolves over time, as well as insomnia is a frequent problem, but can typically be seen to reduce over time. It can be taken with food especially if it causes any nausea. And again, that is something that will reduce over time. Because it can cause serotonin syndrome, we want to assess what their cardiovascular status is prior to initiating therapy. And because therapeutically what we're looking for is relief of depression, then we want to see an improvement in mood, a decrease in restlessness, decreased agitation. Those are the things that we are going to be looking for. Now, SNRIs, or serotonin and norepinephrine reuptake inhibitors, again are going to inhibit the reuptake, this time not just of serotonin, but of norepinephrine as well. We want to assess their history, looking for hypertension, substance abuse, and renal and hepatic function. These are medications that require a gradual decrease before being stopped. Sudden discontinuation can cause a rebound of the symptoms that we're treating, and again be more severe than prior to starting the drug. Common side effects typically are dizziness, drowsiness, restlessness, agitation, nausea, and anorexia, and most of these will diminish over time. Most of your SSRIs and your SNRIs have similar interactions. Obviously, we're not going to take them with their MAOIs. We don't take anything with an MAOI. Cimetidine is another medication that can increase the availability of your SSRI or your SNRI. And haloperidol, these are medications that should be avoided with the use of your SSRIs or SNRIs. TCAs, or tricyclic antidepressants, also inhibit the reuptake of norepinephrine and serotonin. One of the big differences is that they have lots of anticholinergic side effects, and they have a very long half-life. So we've mentioned anticholinergic side effects, hypotension, sedation, dry mouth, constipation, blah, blah, blah. But think about that in terms of what patients might not be good candidates for TCAs. Obviously, a patient with glaucoma, patients with cardiovascular disease, because it can cause tachycardia, patients with prostate disease because of the urinary retention. So all of these anticholinergic effects are more than just side effects. They can interfere with other problems or comorbidities that my patient may have. So you want to think beyond just a list of side effects. And what does it mean for the real person that's taking this medication? Who might be taking it, and what else is going on with them? Tremors and Parkinson's-like symptoms are another side effect, and we want to know about these. This pill rolling tremor, changes in gait, drooling, flat affect, quickly, because if it's not caught in time, then these may not be reversible symptoms, and medications for Parkinson's aren't going to help if it's a side effect of a TCA. TCAs are going to interact with other CNS depressants, other antidepressants, anticholinergics, and sympathomimetics. So I need to make sure that I get a good medication history. Most of your TCAs do have some sedative effect. Some are more sedating than others. And again, we typically will build a tolerance to some of those. Keep in mind that with all antidepressants, there are natural or herbal products that patients might be using as well. They might be using ginkgo because they think, oh, they need to stimulate their brain. They're feeling like they can't connect to thoughts. I know you're probably thinking I need some of that today. They just feel like their brain isn't working. So ginkgo is supposed to stimulate brain function. St. John's wort is an herbal that's frequently used for depression and should not be taken at the same time as any of these antidepressants because all of the side effects that we've talked about will be worsened by adding that. Atypical antidepressants can inhibit the reuptake of serotonin and affect the activity of norepinephrine and dopamine. Probably one of the most common atypicals is bupropion or Wellbutrin. Wellbutrin is also used for smoking cessation. We want to avoid using the atypical antidepressants for any patients who have any psychoses because of their effect on dopamine. When we increase dopamine availability, it can increase the psychotic symptoms that the patient is experiencing. So again, that goes to assessment. Atypicals have an increased likelihood of causing seizures. Very common side effect, or serious side effect, I guess, with bupropion would be seizures. So if they already have a seizure disorder, we want to make sure that they don't take that medication. And with almost any medication, we want to assess liver function. Atypicals sometimes are difficult for patients to take, as are the TCAs and MAOIs because of the dosing schedule. And they're typically taken 2 to 3 times a day. And that can be difficult for patients to keep up with, especially once they start to feel better. And then, of course, it's not going to work as well, and they start to feel bad again. It may cause GI upset, and so taking it with food would be okay. Again, multiple medication interactions. Sorry, a little slip of the tongue there. Cimetidine, again, cimetidine can decrease the breakdown or metabolism, and so these medications are more available, and we're going to see more side effects. May not always see a better therapeutic response, but more side effects. Now, it's interesting that bupropion is used for smoking cessation and is sometimes used with nicotine replacement, such as the patch or gum or whatever. But patients need to know that it increases their risk of high blood pressure by using the atypicals with nicotine replacement. And then we want to avoid it with levodopa because levodopa is stimulating dopamine, and we're going to see an increased effect of the levodopa. And then antimanics, typically this is going to be used for bipolar disorder. Mostly we're talking about lithium. It has the ability to moderate extreme shifts in mood, which is the problem with bipolar disorder. And lithium has no therapeutic effect or non-therapeutic effect as far as mood alteration goes in people without bipolar disorder. Bipolar we used to call manic depressive disorder. So that reminds me to tell you that if you don't understand depression, if you don't understand obsessive compulsive disorder, if you don't understand bipolar disorder, panic disorder, these are things that you might want to refresh your memory of. So the action of lithium is that it affects the transport of sodium across the cell membrane. And so what you might be thinking is, so what? What does that mean? And what you'll learn as we go along, sorry about that. Talking too much makes me cough a lot. Is that the movement of electrons, or what we consider electrolytes, sodium, potassium, calcium, across cell membranes initiates an action potential in that nerve cell or in any cell. So it's true of the nervous system, it's true of the cardiovascular system. And so you'll see this idea or this type of action numerous times as we talk about different meds. So what's happening then is in the nerves that affect mood, the more sodium that moves across, the more excitable those nerve cells become, and so we're going to see that alteration in mood. And so we get that manic phase, that constant movement and darting from one activity to another. And most of us think, well, that doesn't sound so bad. The biggest problem is that it's so short attention span that there's never a completion of a task. They could be right in the middle of something, drop it completely, move on to something else. They just never finish anything, and their thoughts are like that too. They can't finish a sentence because they just keep flitting from idea to idea and task to task. So what this means then, when it affects the transport of sodium across the cell membrane, is that it stabilizes the nerve impulses. So I told you all that long story just to tell you that it stabilizes the nerve impulses. Lithium does not have any sedative properties, so it's not going to cause sedation, but it is going to smooth out that manic phase. It also doesn't have any antidepressant properties, so it's not going to affect the depressive state that the patient goes through with bipolar disorder. The main thing about sodium, or about lithium, is that it acts like sodium in the body. And so you have to think, well, what does that mean then? What it means is that it takes the place of sodium. So if I don't have adequate sodium, lithium is going to stay in the body and act like the sodium would. So anything that decreases the amount of sodium in our body, or that causes sodium loss, can increase lithium toxicity. And so that's another clue to you about what kind of problems we would have. Obviously, we can have toxicity with lithium, and we're most likely going to see that when the patient has inadequate sodium. So ask yourself, what conditions can cause decline in sodium? What's going to cause hyponatremia? Diarrhea, vomiting, poor sodium intake. Are there any medications that can alter sodium? And obviously the first thing that typically comes to mind is diuretics. That's how they work, get rid of sodium. So these things are going to increase the likelihood of toxicity. So how will I know if my patient is toxic or developing lithium toxicity? Unfortunately, some of the things that can cause lithium toxicity are also symptoms, such as persistent vomiting and profuse diarrhea. So anytime that my patient has these, then if I know they're on lithium, I'm going to be thinking, toxicity, need to be worried about that. Or toxicity, I need to be worried about that, because that could be what's causing the vomiting and diarrhea, as opposed to the vomiting and diarrhea causing the toxicity. Hyperreflexia, weakness, fatigue, all the symptoms of hypernatremia. Decreased renal function, because the body's not able to get rid of it. So we want to make sure that our patients are not on a salt-free diet if they're taking lithium. So that was going to be a point of teaching. Polyuria is a side effect. And again, because lithium mimics sodium, as the body excretes the lithium, it's going to take water with it. So what kind of patients would this polyuria be a problem for? So we want to think about, who might have a problem with urinary retention? Who might have a problem with possibly becoming dehydrated? And so that again is going to tell us, if they have a symptom of polyuria, what do I want to make sure to teach my patient? So these are questions that you can ask yourself and come up with the answers, and that leads you to how am I going to care for this patient taking lithium. So therapeutically, what we want to see is a decrease in mania and fewer manic episodes. And we want to be observant for toxicity, as well as monitoring that sodium level and renal function. So this is quite a bit longer than I anticipated it to be, so feel free to take it in short chunks, though telling you that at the end is not going to do you much good. And then if you have trouble, you can always go back to another section. So that does it for sleep, anxiety, and mood, and we will move on to another topic. Thanks for listening.